Okay, so I think it is time to start. It's 9 o'clock British time. I'd like to welcome everybody to this webinar from Thrombosis UK, which is looking at pregnancy, thrombosis and COVID. Very much a feature of the last 3 months. It's actually quite hard to believe we're running a webinar like this when we think about how life was 3 months ago. So how we're going forward today is we've got 3 lectures from 3 fantastic international experts. I am Professor Beverley Hunt. I am Medical Director of Thrombosis UK and really thrilled to have such wonderful speakers with us today. So we're going to talk about COVID, we're going to talk about pregnancy and its thrombotic risk, how the two interact together, what the current British guidance say, and with some help from Saskia, what the guidelines in the Netherlands say as well. Before we start, I just wanted to remind you all of the pathophysiology of COVID, because I think that a lot of people who work in the pregnancy field haven't seen that much. So just to remind you what is happening. So when one acquires COVID, it is binding and entering cells through the ACE2 receptor. And in the lungs, this is expressed on the pulmonary epithelium. It's also present on endothelium, macrophages, and lymphocytes. And it seems the more we look, the more we find the receptor. And when we talk about COVID infection, we know that the majority of people, very thankfully, can have minor problems, or they may even be asymptomatic. And in the UK, there's been a lot of interest in anosmia. Some people have been having anosmia as their only symptom, and it can last several months. But the rest of the patients might have fever and a cough, and then get better after 7 to 10 days. Unfortunately, what we really fear is that people develop COVID pneumonia. And we're talking probably about 5% of people who acquire COVID. We know what the risk factors are, that they tend to be older, male, obese, diabetic, with cardiovascular disease. So this really isn't the pregnancy group, thankfully. What happens is complex, but we know there is a massive inflammatory response when we get this pneumonia. And there is activation of all of the inflammatory systems, lymphocytes, macrophages, endothelium, and we have an incredible cytokine storm, which results in the patients being very unwell. And we define these patients into 2 groups. So if you get the pneumonia and you're hypoxic, you require admission to hospital for oxygenation, and we call those who only require supplementary oxygen as moderate, but unfortunately some people need mechanical ventilation, and those we would call severe. And we also know that with that cytokine storm comes a profound prothrombotic state. And in patients who are not pregnant, we're seeing extraordinarily high levels of fibrinogen. I've seen fibrinogen levels of 14 grams, whereas normally we know fibrinogen is 2 to 4 grams per litre. In pregnancy, it will be 6 grams. So the question a lot of people are asking is if you have a pre-existing inflammatory state, such as obesity, cardiovascular disease as you get older, is this the thing that is required for the pneumonia to happen? So I have just laid down what is happening in COVID, and now I would like to stop screen sharing and move on to ask our first speaker to tell us about COVID and pregnancy from her perspective. That's Dr. Claire McLintock. She's a hematologist based in Auckland, and is very proud of the fact that in the last 2 weeks there have been no cases whatsoever of COVID in New Zealand. It's a wonderful thing to hear. She graduated from the University of Edinburgh in Scotland, so you might find her accent absolutely charming, and she's based in Auckland in the National Women's Health Centre, and she's currently president of the International Society of Thrombosis and Hemostasis and a member of the ISTH World Thrombosis Day Steering Committee. And of course, her interests of thrombosis and hemostasis in women, especially in pregnancy. So Claire, thank you so much for joining us. Please, would you tell us your thoughts?
Hi, so good evening, everyone. That's the time it is here. Good morning, whatever time of the day it is. A good day to you all. Thanks so much to Thrombosis UK and to Beverley for inviting me to talk in this webinar. And as she mentioned, I'm living in a country where there is very little in the way of SARS-CoV-2 infection and COVID. And in fact, it's now 20 days since we've had any cases of COVID in the country, and we don't currently have any active cases like many, but there are a few countries in the world like New Zealand. So what I wanted to talk to you about tonight was really just to summarize what we understand now about SARS-CoV-2, COVID-19 and pregnancy. So I'm showing you, first of all, this is a picture of Edith Sheila. Now, she was the wife of Egon Sheila, who was alive in the early 20th century at the time of the so-called Spanish flu, the pandemic of H1N1 influenza. And this is a picture of Edith drawn by her husband, painted by her husband, and she died 6 months pregnant in October 2018 in the second wave of that pandemic, which was the worst and the most feared, the most lethal wave of that pandemic. And her husband Egon died 3 days later at the age of 28. So this isn't the first pandemic that we've seen. You may all remember also just in 2009, 2010, we had a second H1N1 pandemic, which swept across the world, was declared a pandemic in the middle of 2009 and continued to 2010. And this is, in this pandemic, there were over 3,000 women in a global review from 29 countries that were published. Over half of the cases published were hospitalized. You can see almost 25% of the cases were admitted to an intensive care unit. And there was a mortality rate with that illness of 8%. And the studies showed that although only 1% of the total world population at that time was pregnant, at any time is pregnant, at that stage, pregnant women accounted for 6.3% of all hospital admissions, 5.9% of ICU admissions, and almost 6% of deaths. And the risk factors for hospitalization, when they looked at it, was young age, different ethnic groups in the UK, Black and other minority ethnicities, in the US, Hispanic and Black Americans, Maori and Aboriginal and Torres Strait Island Indigenous people in Australia and New Zealand, and other specific risk factors like obesity, asthma, and smoking. Now, what made that different from our current pandemic is we had an influenza vaccine, which was quickly modified to cover H1N1 variant, and also we had the availability of giving women Tamiflu to moderate or ameliorate their disease. But it did kill a lot of pregnant women. Then subsequent to that, we had the other beta coronaviruses that caused SARS in 2002 and MERS in 2012. And the overall case fatality rates with these were very high, and there was also a very high pregnancy fatality rate. So in December 2019 and in early 2020, when this virus was first identified and first started spreading, you can imagine that across the world, we were all faced with this idea. We didn't know how serious this virus was going to be. And I started to think, and I know my friends across the world did, would we be faced with yet another illness where pregnant women would be disproportionately affected and we would have high rates of death? This is another picture of Egon Sheila's actually called The Dead Mother, and it was painted in 1911, so way before the influenza pandemic. And we know that at the moment, globally, we've got more than 7 million infections, and the number doesn't seem to be slowing that much, and we've got over 400,000 deaths at the moment. But actually what I'm going to show you now is that this particular coronavirus is not having the same really negative effect in pregnant women. So the questions that I have been asked about this, and I'll try and answer these briefly with some data, is are women who are pregnant more likely to be infected? Are they more likely to get unwell? What are the risk factors for women getting severe illness? What are the maternal and fetal implications of the infection? Is there any evidence of vertical transmission? Is breastfeeding safe? And should all pregnant women admitted to hospital be tested for SARS-CoV-2? So from the Chinese data, that was the first that was released to us, pre-printed quite a while ago now, there were 118 women with COVID-19 with a median age of 31 years. The majority presented in the third trimester, but 92% of those women had mild disease and only 8% had severe disease where they needed ventilation. And in that cohort, there were no deaths. Of the women who had delivered at the time of publication, the majority delivered by cesarean section, but we don't know why. And a number of the women also had their babies prematurely, but we don't have much more information. And in this cohort, there was no description of neonatal infection or death. So already it's looking less severe. And what I want to just now present you is what is one of the largest population cohorts. It's just been published in the British Journal of O&G, the UCOS population-based report, where they looked at women with, who were positive for SARS-CoV-2 RNA or had evidence of pneumonitis. And at that stage in the UK, between the 1st of March and the middle of April, they were only testing women who were symptomatic at that stage. And so they found in that period of just about 6 weeks that there were 427 women who met the criteria of having SARS-CoV-2 admitted to hospital. And you can see that's almost 5 women per 100,000 maternities, so 1 in 200 maternities were affected. Now, these women who presented to hospital were mostly presenting with symptoms in the 3rd trimester, and you can see it's the usual range of symptoms that you get with an influenza type illness. And actually it's a very similar spread of symptoms that you get with all influenza when you start to look at studies. So just some data on these women. Basically, you can see that if you were over the age of 35, you were 2.3 times more likely to present to hospital. And women who were either overweight or obese were 2 and 2.5 times more likely to be admitted to hospital. Also, women with pre-existing medical conditions were more likely to be admitted, in particular asthma, hypertension, diabetes, and also a small number of women with cardiac disease as well. About 1% of the women had cardiac disease. So we're already seeing that there's a similar risk factor profile that you get with pregnant women as you get with the general population. Ethnicity has been talked about a lot, and it also plays a really important role in pregnant women with COVID. And as you can see from these figures here, Black, Asian, and other mixed ethnicities in the UK are really big risk factors for presenting with COVID. And in particular, up here, you can see that Black women in the UK have a very high risk, which is double that of Asian women, and 4 times that of Chinese, and 8 times that of white women. So what happened to these women? Well, about 10% of them needed to go into critical care, 1% needed ECMO, 5 women died, so that's a case fatality rate of 1.2, and the study shows that 3 of those women died from COVID and 2 died from other causes. About 1/4 of the women had evidence of COVID-19 pneumonia on imaging, but a large proportion of these women, you can see, were discharged well. So 93% of women went home well. And at the time of writing, only 6% were still in hospital. So of the women who had an ongoing pregnancy aren't discussed anymore. And you can see that that made up a reasonable proportion, about 40%. But 62% had a pregnancy that was completed. There were 3 stillbirths in the group that were not thought to be related to COVID. 97% of the women had a live birth, and there were 2 neonatal deaths that were not directly thought to be due to COVID. And the median gestation at birth was 38 weeks. And you can see here 3/4 of the women had their babies after 37 weeks, but there were a substantial number of women who did have a preterm birth. Here we look at the mode of birth, and you can see here that the majority of women, about 60%, gave birth by caesarean section, but only a minority, in a minority it was done because of SARS-CoV-2. It was usually for another indication. And you can see also here, a number of women did manage an unassisted vaginal birth, but some had an operative birth. 20% of the women who needed a C-section needed a general anesthetic. A number were intubated for maternal compromise, and a number were intubated because they needed to have an urgent delivery. So what about the neonates? Well, 25% of the infants went to NICU, some of them very preterm. You can see under 32 weeks here, but a number of preterm ones. The infants were, not all, but many of them were tested for viral RNA, and you can see that 6 of them, or 2%, were positive within 12 hours of birth, and 6, or 2%, were positive after 12 hours. Now, the authors of the study have suggested that this does not necessarily show evidence of vertical transmission. It's important to know at this time, women who were giving birth were still were advised to have early skin-to-skin contact, and even though they might wear masks, we can't absolutely exclude that the transmission of the virus may have been in the early neonatal period rather than viral transmission. And actually, when you look at influenza infection rates in infants born to mother with influenza, it's a very similar rate of infection. But importantly, what you can see here is even in 3 women who had pre-labor C-sections, some of the infants did have viral RNA. But again, just to emphasize, we cannot be sure that this was not postpartum early transmission of the infection and not necessarily vertical infection. And just a little bit more information about the issues of vertical transmission. There was a study that showed that 3 infants in the study had IgM to SARS-CoV-2, but interestingly, these infants were all negative by nasopharyngeal swab, and this antibody was present early. And then this is a study from the US that shows that in 32 women with COVID-19, they took placental or membrane swabs from 11 women, and in 3 of these, there was positivity for the virus. All of the women had been delivered by C-section and were very unwell, and we don't know how the membrane or the placenta was contaminated by the virus. We don't know if it was a contaminant, but all of these infants, none of them were positive for the virus. So again, we can't absolutely exclude vertical transmission, and we have to say it's probable, but it's not a big issue. And importantly, the infants born to women, even if they're positive for the virus, the infants do well and they don't get sick. What about breastfeeding? Well, again, viral transmission to breast milk is uncertain. It's recommended that women who have presumed possible or confirmed infection need to follow issues relating to careful hand hygiene and should wear at least a cloth mask when they're breastfeeding or expressing. What about screening in all pregnant women? Well, these are a couple of studies I'm going to show you from the US. So in the first study from Manhattan, at a time when the rates in Manhattan were incredibly high, 215 women were screened in their births at 2 hospitals. They were screened for symptoms, and of the 4 women who said yes, they had symptoms for COVID, 100% were positive for the virus. 211 women didn't admit to any symptoms, and 13% of those women at the time were positive for the virus. In Connecticut, in the US, which is one of the states with a very high rate, or that's had a very high rate of infection, again in a hospital, 770 women were tested for the virus on admission. The overall positive rate was 3.9%, and of the 14 women who had symptoms, the rate was about 60%, but in the 750 women who were asymptomatic, there was a positivity rate of 2.9%. So what these studies have said that of the woman who had no symptoms at admission were responsible for a big majority of the women who actually tested positive for SARS-CoV-2. So clearly, pregnant women, generally younger and fitter, can have the virus and not have any symptoms. And so does this mean we should screen all pregnant women? Well, I think it really depends what the incidence rates and the prevalence rates are in the hospitals that you're working within. And I do know from many of my colleagues across the world that in their units, women are being tested. But in our country, where we can be proud that we don't have very many cases, in fact, I believe that we've only had 4 cases of pregnant women with COVID across the country, I don't think this is where we would want to spend our money in actually testing all pregnant women. So just to summarize, I think we can be fairly confident that pregnant women who are more likely, pregnant women are not more likely to be infected than women who aren't pregnant. And they're not more likely to become unwell than women of the same age who also get the virus. But I want to emphasize the fact that some women with SARS-CoV-2 do become unwell. And a pregnant woman who has severe pneumonia, really, we need to be thinking very carefully about how long or if she can continue with that pregnancy, as because if she's very unwell and unable to oxygenate, then continuing with the pregnancy might really risk her life and the infant's life. So I don't think we should become blasé about it, and I really think we should be considering which of the women that we're looking after will have risk factors for severe illness and pay particular attention to those women. I think the jury's pretty much out on whether or not there's vertical transmission. If there is any, it doesn't seem to be a major problem. Probably one of the commonest reasons that women are having their babies preterm is because of the infection. Breastfeeding is safe and should be encouraged. And testing women for SARS-CoV-2, all women who get admitted to hospital, really will depend on what the prevalence of the virus is within your setting. So thank you very much.
Well, that was a fantastic summary. Thank you so much, Claire. I think that the data from the UK has been really informative, and thank you for presenting it so very well. We're going to move on now because we're going to have questions at the end, and I know that you have views, and I'm looking forward to hearing them. We're going to move on and ask Professor Saskia Middeldorp, who's well known in the women's health circles for her enormous interest in managing thrombosis in pregnancy. She comes from the Department of Vascular Medicine at Amsterdam University. She's a professor of internal medicine, and she has done a lot of research looking at the etiology of thrombosis, clinical implications of thrombotic risk, the development of new anticoagulants, with a particular interest in women's health. So without further ado, Saskia, over to you.
Sorry, I think I was muted, wasn't I? So it's really a privilege to be able to speak on this webinar, indeed on my favorite topic, and that is to try to balance between harms and benefits in terms of VTE in pregnancy, because pulmonary embolism is still the leading cause of maternal death in the Western world, as you all know. And the UK guidelines from the Royal College of Obstetricians and Gynecologists have a very low threshold of giving obstetric thrombosis prophylaxis. What I think is really good is in those guidelines that all women, and I think that is being reinforced so much and so well in the UK, that they all need a thromboprophylaxis risk assessment. But about the management, I think there are also potentially some let's say lower thresholds than in other guidelines or countries. And if I just look at the Green Top guideline from 2015, where, for instance, in the non-hospitalized patients, which is this square here, if you have 4 or more risk factors, you're going to be eligible for prophylaxis from the first trimester onwards. And if you have 3 risk factors, you're going to be eligible for prophylaxis from 28 weeks on. I think personally that this may be for some women a bridge too far, because I think that there is a huge heterogeneity in the cases and the risk factors adding up. As you can see, for instance, 2 cases that I think are notably different. So the first one who would be eligible for antenatal prophylaxis would be a 39-year-old who typically has become pregnant after ART, has a BMI of 31 and now goes visit her family in the US and as such has a transient risk factor for VTE. Or on the other end of the spectrum, a 36-year-old who is pregnant with twins, who's got hyperemesis but is not hospitalized. She's got a family history of VTE and she is known to be heterozygous for factor V Leiden. So these all fall in the same ballpark. And the question really is what I think of that. And we should realize, and this is a summary from the ASH guidelines, the American Society of Hematology guidelines. And I'm not going to ask you to read what is in here, but this is just one table on guidelines for prevention of a first VTE in pregnant women who are known with hereditary thrombophilia. And the guidelines differ pretty severely, to be quite honest. Hence, they are all evidence-based and all led by very important and very knowledgeable people. So what we do in the Netherlands, because that was particularly what was being asked, we lean heavily on the American guidelines. And that is not so strange because I think I was part of that, as was Claire McLintock, whose fantastic talk we just heard. And so we were the international members, I suppose, and the others were from North America. You can say a lot of those things, but it was at least very, very thorough, the whole process, as I'm sure the UK was as well. But I have had the privilege to have this inside experience. So the question really is, are we doing too much? And that is, I think, something dangerous to say from a person who really wants to prevent every single clot in a pregnant woman. However, we should also be realizing that the only thing we can do to prophylax pharmacologically is daily injections with low molecular weight heparin. And I think skin reactions are underreported, but if you go search for them, and depending potentially on the type of low molecular weight heparin, but 20 to 40% of women actually do experience type 4 delayed type hypersensitivity skin reactions. There is of course, always a worry about increased bleeding, although I don't think we have a lot of evidence to tell us that that is the case. And of course, there are consequences of antenatal prophylaxis around delivery and with epidurals. And the pictures you see here are just all from my own practice. And one woman has very mild type 4 skin reactions that are quite tolerable. This is a woman who seeks contact with her doctors because of a pretty large hematoma. It's subcutaneous, so there's nothing to really worry about, but I mean, it's not pretty and it's painful. And here is a woman who has, which is fortunately very rare, has type 1 allergy towards low molecular weight heparin. And here we got into a bit of a struggle to get her safely through pregnancy. So it is not harmless, it's not no harm and benefits only. So how can we strike the right balance? And I think that is what all the guidelines are trying to do. And it is all about absolute risks versus absolute benefits. And this is very difficult because, believe it or not, but we do not have appropriate trial evidence on the efficacy of VTE prophylaxis in pregnancy or postpartum periods. I think this is really amazing if you consider the fact that so many women throughout the world are being offered these types of prophylaxis. And we have to extrapolate for antenatal prophylaxis from very different populations, like extended prophylaxis after having orthopedic surgery, for instance. Then what about the harms? What about the bleeding data? The bleeding data for pregnancy antenatal prophylaxis, we have to get from cohort studies or from smallish low molecular weight heparin trials that were actually not designed to look at VTE, but look at pregnancy complications or miscarriage. And I'm absolutely sure that they did not collect bleeding very well. And there is massive underreporting of the bleeding risks. So where does that lead us in terms of how do we get to recommendations? I am showing you the ASH guideline slides that you can download for free from the ASH website. And I think these are very much in line with the UK because this is the easy part. These are the recommendations in women who have a history of VTE. And it's very clear that all these women deserve and need postpartum prophylaxis, even at a strong recommendation level. There's no discussion about it. And there's only a very small proportion of women that are in the lower bottom here, provoked VTE with a non-hormonal risk factor, who do not require antepartum prophylaxis, but all others do require antepartum prophylaxis. And in my view, we should give them antepartum prophylaxis from the start of the pregnancy. And there really is no rationale to look at women who have a high enough risk to only start at week 28, because the risk is more or less similar throughout the trimesters. So just a bit about numbers, but I will go through this quickly. The relative effects are being summarized because I said something about antepartum prophylaxis. And we should realize that the relative effects of low molecular weight prophylaxis are, as I said, not based on very good direct evidence in the pregnant population. And you can see that antepartum prophylaxis compared to no antepartum prophylaxis in pregnant women results in 26 fewer VTE events per 1,000 women treated. If for those who like figures and like evidence-based medicine, there's something very funny here, because you can see that low molecular weight heparin seems to protect against bleeding in pregnancy. And we must realize that these, as you can see from the confidence intervals, are based on very small numbers and have all the problems that I've just told you about underreporting in trials not designed to look at the side effects of low molecular weight heparin. So for postpartum prophylaxis, a very similar relative risk reduction. And you can see that there is a slightly bigger benefit of 48 fewer VTE events per 1,000. Now, this is about women with a history of VTE, and I think that is a no-brainer for all of us. But here we go, how to deal with women who are known to have thrombophilia. And this is a summary that comes from a very nice pocket guide that Claire wrote together with the chair, Shannon Bates, of the 2018 ASH guideline. And I think this is a beautiful summary, because what this shows are the recommendations based on the type of defect, based on whether a family history of VTE is present or not, and also gives you the strength of the recommendation. As you can see, it's very orange. That's our national color, but here it means conditional recommendation, meaning that we really don't have a lot of evidence. And within the panel, and after some great deliberation, despite the fact that the evidence was small, we did get out some strong recommendations about postpartum prophylaxis. But this is like a 2 or 3 slide page pocket guide that is really easy, I think, to have in your drawer or on your computer. So there's one final thing that I'd like to discuss, and that is that if we have now decided that a woman needs antepartum and or postpartum prophylaxis, what dose does she need? And again, here there is really no evidence. Even though there is no evidence, there has been long discussions, as Claire memorizes, in the panel meeting. And we finally, as a whole panel, came up with the fact that we suggested against intermediate dose low molecular weight heparin prophylaxis based on a fear of bleeding, and also the absence of any evidence that intermediate dose low molecular weight heparin is more effective than standard dose. And for postpartum, a shorter period of time, a higher thrombosis risk, the panel couldn't make up their mind and suggested either standard or intermediate dose low molecular weight heparin prophylaxis. All very low certainty evidence. So what I would like to end with is one of my babies, my own babies. I've got 3 big babies, my sons, but I also have a few babies that are trials in this population. And this is the high-low study where we actually look at an intermediate dose versus a low dose, low molecular weight heparin in pregnant women with a history of thrombosis. And we hypothesize that intermediate dose is superior. And just to show you that it's very easy, and I know that we shouldn't waste too much time on this because the study is actually going to end quite soon. Intermediate dose low molecular weight heparin versus low dose, and we're simply counting recurrences. We're prospectively collecting all bleedings, and that is why I know for sure how much underreporting there must have been in the other trials. And we are actually have randomized more than 1,030 women as of today in 9 countries and over 70 sites. So to conclude, most women with a history of prior VTE should receive antepartum and postpartum low molecular weight heparin prophylaxis. Pregnant women with no personal history of VTE may merit low molecular weight heparin prophylaxis, depending on their family history of VTE and whether there is underlying thrombophilia. And personally, I think that the adding up of risk factors in the UK guidelines are a bit too much of a stretch. But that is based, of course, on the same evidence as the American guidelines that differ considerably. And the optimal prophylactic dose is unknown. But I can tell you, by 2022, we will at least know the results of the high-low study. And with that, thank you very much for your attention.
Fantastic. Thank you very much, Saskia, for bringing us up to date with thromboprophylaxis globally. And we're going to move on now. We're going to come back to you because we'd love your views later on some of the questions that have come through. So the last talk comes from Dr. Jan Daru. She's an academic clinician with an interest in women's health, specifically obstetric hematology, and she's based in a clinical epidemiology department at Queen Mary's University. She's had an unusual medical career. She did her PhD on anemia in pregnancy in high and low income countries. And she's worked at the WHO headquarters in Geneva on antenatal care, looking at iron deficiency and policy in different countries. She's also worked with the BSH and co-authored our guidance on anemia in pregnancy. But most importantly of all for today, she's a member of the Royal College of Obstetricians and Gynecologists COVID-19 guidance team. And they have produced rapid guidance for managing women with COVID-19 during pregnancy and the puerperium. And she's going to talk about that today. Jan, over to you.
Thank you very much for that introduction, and also thank you to Thrombosis UK for inviting me to give this talk. I'm essentially just going to summarise the RCOG's response to the COVID-19 pandemic and the approach that they've taken, which is actually a little bit different to the normal guidance processes. For those members, both on the panel and those listening, you'll know that actually writing a guideline takes absolutely ages, and to produce something in the time of a global pandemic very quickly can actually be quite challenging. So Jo, could I have the next slide, please? So these are just the 3 key areas I'm going to cover. The COVID-19 guidance, I'll briefly talk about the suite of the guidance that's been produced. The RCOG obviously is a governing body that oversees all obstetrics and gynecology within the UK. So they've produced a suite of guidance that covers everything from gynecology, gynecological oncology, as well as maternity services. So I will try and touch on that a little bit. I'm also going to just talk briefly about the methodology that's been used specifically for this suite of guidance and how that's been implemented. And finally, the key recommendations specifically with reference to thromboprophylaxis for pregnant women during this pandemic. Next slide, please. Okay, so what has been developed? Well, actually, there's been an entire suite of guidance documents, and there is a landing page on the college's website, a link for which I've got at the end of my slides, which actually shows the range of different specialties and subspecialties that sit within women's health, all of whom have their own perspectives and their own interests in terms of what can and can't be delivered within the period of this pandemic. And for those of you who work across different disciplines, I would urge you to just have a quick look at that guidance if you haven't already tried. And this has a continual review and revision process. And this is actually quite important because when there is an evolving pandemic, as the speakers before have suggested, often the evidence base is changing on an almost daily basis. And for guideline members and for policymakers, that's actually particularly challenging. And how can this best be addressed? Well, actually, that's part of the problem. And I'll talk through what we've done at the college for this. And I would just urge those people that are listening, that the COVID-19 pandemic in pregnancy, the version 10 is the most recent version of the guidance. Next slide, please. So the methodology that's been used for this guidance development as normal is based on a review of the literature. But in this particular pandemic, this is a literature review that occurs on a weekly basis and is reviewed by clinically and academically trained clinicians that sit within the college of which I'm a member of that panel. But interestingly, it's also based on feedback that is provided both from stakeholders that are clinicians, so midwives, obstetricians, other specialists, but it's also based on feedback from patients and women. And this is incredibly important in making sure that the guidance is actually fit for purpose and is something that is relevant to all the stakeholders that are involved in this. In particular, when there isn't evidence or there's very poor evidence, the best thing that we can use is contact experts within the area. So Beverley and Claire have been instrumental in ensuring that the guidance that's been created for low molecular weight heparin prophylaxis, specifically during this pandemic, is very much based on consensus, because we just don't have the data to recommend what we absolutely should be doing during this time. And finally, and most interestingly, that this is a live guidance, meaning that it's updated regularly. So rather than a guidance document being created and then it becomes something that is verbatim essentially and followed, this is a moving, changing document, and it changes based on the review and the feedback that we're getting. So this is a completely different approach to guideline development, and something that's quite new for me. Next slide, please. So you will have access to these slides afterwards, but I just wanted to summarize the key recommendations that we have at the moment with regards to how should we tackle VTE prevention during this pandemic. So for those women who are self-isolating at home, the advice is to stay well hydrated and mobile throughout this period. All women should have a VTE risk assessment in relation to the RCOG Green Top Guidelines number 37A, and Saskia mentioned this in her talk. But it's important to remember that SARS-CoV-2 is actually a transient risk factor. So ordinarily, those women who perhaps maybe have only scored 2 or 3, if they then have a subsequent infection and they are self-isolating at home, they may then need a short course of thromboprophylaxis during their pregnancy. So it's important to remember this. And following on from that, if women already have thromboprophylaxis prescribed, this should continue. For those women or for those clinicians, so community midwives who are having risk factors.
Webinar. Ik dacht dat ik je wegdrukte, maar ik wil weer wat.
Who have concerns about the risks of developing a VT, there should be a clinical risk assessment. This could be either done in person or remotely. And finally, as this guidance document is used by a variety of different clinicians in different clinical areas, the college has advised that the local procedures are followed. And this is largely to ensure that in certain areas where perhaps prescriptions of low molecular weight heparin or dispensing of low molecular weight heparin is done in a slightly unusual fashion, that is allowed to continue during this pandemic. So, for example, we know that there are certain areas of the country within the UK for which primary care physicians are very happy to prescribe low molecular weight heparin under the advice of a secondary care practitioner, whereas there's other more urban centres where actually this is dispensed and given out from secondary care. So it's important to just mention that this may vary and your local procedures should be followed. Next slide, please, Joe. So now, for those women who are self-isolating, so the duration of thromboprophylaxis is really only necessary for the acute phase of the illness. So when women are unwell, so between 7 and 14 days while they're self-isolating, because this is, for all intents and purposes, a transient risk factor. For those women who have ongoing morbidity, whether this is obstetric or otherwise, the advice is to please seek some advice from a clinician with expertise in managing thromboprophylaxis in pregnancy. For any women that are admitted to hospital with either suspected or confirmed COVID-19, the advice is that they should receive prophylactic low molecular weight heparin unless birth is expected within 12 hours. And this is to ensure that regional anesthesia can be administered to these women. For those extremely unwell women, which thankfully there haven't been that many across the UK at least, the advice is to consult, again, an expert, so either a senior obstetrician or a VTE expert, about the absolute dosing strategy. And this relates to Saskia's slides in terms of, well, what is the optimum dosing strategy? Should it be high dose? Should it be low dose? And with the absence of evidence that we have at the moment, the advice is to seek some sort of consensus amongst your own local processes. For those women who are hospitalized with confirmed COVID-19, they should be receiving thromboprophylaxis for the duration of their hospital admission, but also for 10 days afterwards, once they're at home in the community, again, to allow for any reduction in mobility, etc., to be accounted for. And for those women with persistent morbidity, again, speak to your local experts, come up with a relevant, appropriate dosing strategy. For the postpartum women, those women who were admitted with confirmed or suspected COVID-19, again, they should receive low molecular weight heparin for the duration of their inpatient stay. So low molecular weight heparin for 10 days postpartum. And again, consider extending this, particularly for women who have had a significant obstetric event intrapartum or postpartum. So an ongoing infection, perhaps a wound debridement that needed to take place. Those women may need some additional thought for the duration that they will require thromboprophylaxis. Again, I would urge the listeners here to understand that this is essentially an evidence-free zone. So all of these are caveated with the fact that they may be updated in due course, and I would urge all of you to keep up to date. My next slide, please. So these are just 3 key references and links that I would like to make available to everybody here. I've added a reference to the COVID-19 hub. Now this would give you direct access to the entire suite of guidance that's been created by the college. There is also a Q&A section within this hub, which essentially answers questions that perhaps women or their partners or families may have with regards to how is COVID-19 being managed in pregnancy, what are the local service changes that may be occurring. So again, that may be a useful resource. I've linked to the most recent version of the COVID-19 in pregnancy guidance. This is version 10 that I mentioned. And finally, I would just like to draw your attention to the fact that the college has created a monitored mailbox, which is monitored on a daily basis, where we're very happy to receive comments, questions, any feedback on the entire suite of guidance. And this again is reviewed on a daily basis, and we are responding to these queries as and when we can. Thank you very much.
Thank you very much, Jan. I'm afraid Jan's got a very crackly internet connection, but we did manage to hear everything, so thank you for that. I don't think I'm impressed with your internet provider.
No.
Anyway, let's crack on. We've got quite a lot of questions here, and we need, I think, to really focus down on thromboprophylaxis with the COVID pandemic. And I think that we need to take on some of the questions, and we want to know from everybody on the panel how they think about these things. So we've got 2 to start with. So what dose of thromboprophylaxis would you use if you felt someone was at risk? And the second part to that question is, would you add in aspirin? So where should we start? Claire, do you want to start?
So, I mean, for me, one of the things I think is very important is I don't think all women who've got SARS-CoV-2 are the same. So I think women with asymptomatic or mild disease, in my opinion, I don't feel strongly, certainly if they're self-isolating at home, I do not think that they would need thromboprophylaxis. And if they were admitted to hospital in labour and they're very mild, again, to me, unless they've got a whole raft of other risk factors, I personally would not feel strongly that they need thromboprophylaxis. But if we imagine there's a more significantly unwell woman with, as you outlined it before, moderate COVID, so someone who requires oxygen support, then I think giving thromboprophylaxis would be a good idea. She's definitely going to be an awful lot more immobile. And my tendency would be to offer her weight adjusted, given that it does seem to me that when you get sick with COVID, your blood is really very sticky. So while Saskia knows that I don't generally offer weight-adjusted thromboprophylaxis to pregnant women in general, I think that this might be one setting where I would do it. And I think that the recommendations that were put out by Guy's and St Thomas's about the weight adjusting, I think that was reasonable. Perhaps you can share them later. For a woman who's very sick with COVID, so who's got severe COVID, I again would still use weight adjusted, and I don't think that I would make the move that other people have done to move to therapeutic doses of anticoagulation, unless you have a clinically suspected PE that you can't diagnose fully. And no, I would not add an aspirin for any woman, unless you were trying to minimize the risk of preeclampsia, but that's a different disease process.
Thank you. Saskia, what's your view?
I very much echo Claire's comments. So we have had 2 handfuls of pregnant women during the pandemic in our own hospital. And basically, we do not treat them very differently from other COVID hospitalized patients. Meaning that if they're hospitalized, they receive prophylaxis in a standard dose. And for a standard dose on the wards, and we have luckily, we didn't have any ICU admissions of pregnant women. So these were all patients on the wards, and that is a standard dose, but we do dose adjust to weight, but not in intermediate dose adjustment. So it's really prophylaxis, and then a double dose if they're over 100 kilograms. I mean, you have to come up with something in your own hospital. That's what we did. And I think a very good and important question is whether it's worthwhile to extend, as is in the guidelines from the UK. And I think that is extremely reasonable if a woman is discharged because when she's still ill at home, in bed at home. But I think, at least in my experience, there's also a lower threshold to hospitalize women who are pregnant with COVID. So they are just a little bit less ill than the regular ward patient. At least that was the way it happened under my eyes. So we didn't extend prophylaxis in those women that we admitted. And I would definitely not add aspirin for this reason.
So I think that's such a good point, because if you're not pregnant, you are only getting admitted with COVID if you've got respiratory failure, essentially. Exactly. And with pregnancy, we are admitting women who might have a little bit of COVID, and they might be delivering and everything. And we need to recognise that COVID is a spectrum of disease, and we shouldn't worry too much unless they've got moderate or severe problems, i.e. that they're hypoxic. Jan, what do you think?
I completely agree. And the RCOG Green Top guideline has exactly what both of the previous speakers have mentioned. It's weight adjusted only. And that is what I would recommend in this situation.
Okay, so having covered that, can we just go back to extended thromboprophylaxis? Claire, what are your views on extended thromboprophylaxis here?
So again, I think it is important to look at to see what badness of COVID the woman has. So yep. Moderate to severe bad COVID, and whereas people have said they're likely to be a little bit less morbid. And what I understand also with COVID is if you've had relatively severe disease, there's quite a lot of fatigue afterwards, even, you know, in the general patients who get it. So I would anticipate that a pregnant woman is going to feel even more fatigued and probably not as mobile as normal. So I think extended prophylaxis once she's gone home, especially because she's got a number of risk factors. She's less mobile, she's pregnant, she's been unwell. So I think extending the prophylaxis is a good idea. How long really depends on the individual situation. If a woman got admitted early in pregnancy, I don't think I would continue it for the rest of her pregnancy, but maybe for 3 to 4 weeks once she's been discharged home. And I think one of the reasons I feel relatively comfortable with that is that overall the risk of bleeding during pregnancy, not around the time of birth as much, but during pregnancy is relatively low. And I think that's what we're trying to keep these women safe.
Okay.
Yeah, that's what I would
Saskia, you touched on extended thromboprophylaxis. Should we manage pregnant women in the same way that we manage non-pregnant patients with COVID?
I think so, although of course we have to realize that pregnancy is a major risk factor for VTE, clearly, otherwise we wouldn't be sitting here. But we should also realize that the daily risk is a lot higher in postpartum women. So for postpartum women, my views or my, let's say, risk-benefit estimates are different. Of course, they also tend to bleed a bit more, if particularly directly after having given birth. But the pregnant women we have admitted were, as I said, they were ward patients. They were only for 1 or 2 days. They had 1 or 2 liters of oxygen, and we did not. And it was basically to see what, where were they going when we admitted them. I don't think they would have been admitted if they were not pregnant. So those women were not on extended prophylaxis. Now, it's totally different for me if it's postpartum, it's been a C-section where there usually would not have been an indication for extended prophylaxis. And it was not a regular swab that was done during the epidemic in our hospital on all deliveries. All these women were swabbed. So we had a couple of those, but if they had symptoms and were ill, then I think it's very, very good idea to extend prophylaxis. So again, it is it's a matter of really weighing the individual risk and the individual risk assessment. And we didn't really talk about obstetric risk factors, but clearly they can all add up. And I think there we would definitely lower the threshold based on COVID. But then I'm saying COVID, which is the disease rather than the virus.
Okay. Jan.
So I completely agree. I would just urge those people that are perhaps based in hospitals where you don't have easy access to a VTE expert and you're perhaps phoning a friend, just make sure that those lines of communication are really clear and that you are really clearly spelling out what the risk factors are, which are permanent and which are transient, and then making an informed decision after then. And it's also really important to explain to the women why it's important to take low molecular weight heparin, particularly if they're in the postpartum period, because sometimes they just forget and they lose interest and they're so consumed with looking after the baby, and then they come back in with a clot, and that was completely preventable if we made sure that communication was really clear.
Okay, thank you. So looking at the questions, someone said, I'm going to give low molecular weight heparin to every woman with COVID, which I think we'd all disagree with, because I think that we'd consider that to be over-treatment. Someone else has said, what is intermediate dose low molecular weight heparin? And that's really a bigger dose than you'd give normally, but not full dose. But somebody else is asking, what are the indications for full dose low molecular weight heparin in pregnant ladies who have COVID? Claire, can you take that on?
So in my opinion, the only indication for full dose therapeutic anticoagulation in a woman with COVID is a woman who has either presented or developed a proven DVT or PE, or a woman whose clinical situation and markers deteriorate so that you think that clinically she's likely or possibly has a PE, so she might become more hypoxic, more tachycardic, clinically unstable, but in such that she's too unstable to have imaging, so that you make, in that situation, you make a clinical diagnosis of a PE because you exclude other causes, and then you would introduce the dose of therapeutic. But those would be my cases. I think we don't have enough information, especially in a pregnant woman, to be increasing the dose to therapeutic outside of those parameters.
Saskia?
I totally agree, and we are in the lucky position that we image everyone from ICU. We had enough personnel to do that. I mean, I realize that is easy to say, but we know that the prevalence of PE in women with a suspicion outside the COVID era is extremely low. So I would really press on to go for that objective test. But clearly, I understand that in pandemic times that
and you're using CTPA, are you?
We are using CTPA also if patients are being ventilated, and we just have like 4 people going to the radiology department with an ICU patient. And we would definitely do that for pregnant women before we would install therapeutic dose, low molecular weight heparin. But clearly I understand that that cannot be done for everyone.
Yes. So, I mean, none of us are using VQ scanning because it's actually a risk for the healthcare workers, and it's just quite difficult for someone who's ventilated. Jan, do you disagree with anything?
No, not at all.
Okay. Now, we're coming to the end, but here's a question for which I don't quite know what the answer is. When we started out in the UK, we listed people as vulnerable and they shielded, and we listed pregnancy as a vulnerable area for COVID. So why did we do that? Jan, can you tell us why we did that?
Well, it's a really interesting point, and I would say that actually the RCOG were not aware that pregnant women were going to be classified in the vulnerable group. And it then meant that actually there was no evidence base to back that up. And I think the decision to classify women in the vulnerable group essentially was extrapolated from those women or those cohorts of patients who would ordinarily be receiving the flu vaccine at the beginning of any sort of flu season, would therefore be classified as vulnerable. And since then, there's been quite a lot of backpedaling. This is particularly relevant for healthcare workers who are also pregnant, because actually the majority of them are completely fine. And we've received plenty of emails from healthcare workers saying, actually, I'm very happy to carry on working or to do what I can within this pandemic. So actually, I think the advice is that was perhaps a bit presumptuous, and the data that's coming out now is suggesting actually that they are not at any increased risk. It's just if they do get unwell, they're at higher risk of having significant morbidity.
Okay, did this happen in the Netherlands, Saskia? Did you have to declare that pregnant women were high risk? I mean, I think it's because we're all scared of H1N1. I have an interest in ECMO.
Yeah, so this was not so much
that period. So many pregnant women required ECMO because they had such bad pneumonia.
Yeah. So of course there were personal. It was very. It's not been that much of an issue, I think, in the Netherlands. They were not on the vulnerable list, but clearly everyone is indeed, as you said, with previous experience. I mean, we've had Zika, you know, all those viruses where it's unknown. I think it's very reasonable to be very careful with your pregnant women when you don't know much. I think we are now in a different situation where we know much more than in the beginning.
Okay. Claire, did you declare pregnant women vulnerable in New Zealand?
I think they were actually. We were following the RCOG's guidelines, but we didn't go for it in quite the firm way. I mean, I think we have to be clear that I do think that people followed the H1N1 concern because we didn't know, there was no information as to whether or not pregnant women would become unwell. And in most other pandemics, pregnant women did get more unwell than women of the same age who weren't pregnant. I mean, there were all sorts of weird things that went on at the beginning of pandemic, from encouraging herd immunity to talking about, you know, pregnant women being vulnerable. And I think it's been a time of very rapid learning. And I think we just need to be really quite reassured and quite grateful, actually, that we're not facing, you know, terrible morbidity and mortality in pregnant women, because it's very challenging as it is. And I think that's just a situation that really, I remember from the H1N1 days, it really was really quite horrendous, the work of looking after a very, very huge sick cohort of pregnant women. And it doesn't bear thinking about, actually. I'm glad.
Okay. I think we've passed our allotted time. I want to thank our amazing panelists for a wonderful selection of experience from across the world. Thank you all very much. I'm going to hand over to Jo Jerome, who's Chief Executive of Thrombosis UK, just to tell you a little bit about Thrombosis UK. Over to you, Jo.
Thank you, Beverley. And can I echo your thanks as well to the speakers this was an excellent webinar, and also to all the attendees. To quickly update the attendees that we will be sharing the CPT certificates within the next week, so they will be coming through to you by email. And we are also planning further webinars and welcome suggestions for these or feedback on webinars. Thank you very much. For those who haven't visited Thrombosis UK before, we're a registered charity. We rely totally on donations and fundraising, which obviously during this time has been impacted by the COVID pandemic. But we have been determined to keep providing resources, support, webinars, education in this fashion to support both healthcare professionals, patients definitely through this time, and the general public, so that they feel reassured and informed. If you would like to help and support in our work, you can do so by donating to the charity via the website www.thrombosisuk.org. And we welcome all your support, both through donations and also through feedback. Thank you very much, everybody.
Yes, so thank you. And thank you so much to the panelists. Yay, have a lovely day, everybody.
Thank you, bye-bye.
Bye.
Bye. Bye.